Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by Dixon's Chemist, who are the experts in LDN and associated treatments in the UK. Dixon's Chemist are the most cost-effective for LDN in all forms within the UK and Europe, maintaining safety standards far in excess of what is required. Why would you choose to get your LDN from anywhere else? Call 0141 404 6545 today to speak to their LDN experts. I'd like to introduce my guest today, Dr. Julia Piper from Private GP Services in Leicester in the UK. Thank you for joining me today, Julia.
Oh, it's a pleasure. Lovely to speak with you, Linda, and all your listeners.
Thank you. First of all, let's get to know you. What made you decide to become a doctor?
Oh gosh, Linda, that was years ago. I think I was only 6 years old.
Oh wow!
And I always wanted to become a doctor. I remember my cousin was a doctor, and I was completely obsessed with how wonderful she was to do this and want to do it. And eventually, she became a haematologist, Liz. And I just never wanted to do anything else. My father said, "Why don't you become an engineer?" And I just couldn't relate to anything else. And that was it, really. People tried to dissuade me over the years for a number of reasons, I guess. To do with the number of hours you're going to have to work. But it didn't quite work. It's like I'm on my right path, Linda, put it that way.
Mm-hmm. Oh, wow. So where did you study?
Nottingham University. So I chose that because it was very beautiful and green, and I liked being out of doors. And I could have gone to London, I guess, because we lived in Kent at the time. But I chose Nottingham, and it had quite a different course. It was you were assessed by continual assessment, so that you had exams at the end of every term, and you became a Bachelor of Medical Science, so you learned how to be a scientist as well. And apart from that, it was very similar to other courses, but it was just this fact that you didn't have to sort of leave everything until the finals. After 2 years, you really sort of kept on top of things as you went through.
Mm-hmm. Okay, so when you qualified, what path did you take then?
Well, I always wanted to be a GP because I loved being out in the community with families and so on. And so I went into vocational training, and I did my own vocational training course, which in those days we were able to choose different specialties. And then we did that for 2 years, and then we had to do a year in general practice. And then I went into a GP practice in Yorkshire, where I lived at the time, and moved down to Hertfordshire, did some general practice there, and then moved up to Leicestershire, which is where I am at the moment. So I had quite a lot of experience in the NHS, before I actually then eventually moved into the private sector. It wasn't really planned, this move into the private sector, only that I guess I wanted a little bit more time with people, and just to have a morning a week where people could just ring me up and say, "Can I have half an hour? I need more time." Because it was so, you were so stretched for time in the NHS, Linda. That was all. And it was never meant to be anything else. But as you know, we all know, life changes and evolves, doesn't it?
Mm-hmm. Hello?
Hello?
Oh, I thought I'd lost
Oh,
you.
yes. So it changes and evolves. And eventually, as I say, I went into the private sector.
Mm-hmm.
And started to see a few patients privately. Interestingly, Linda, over the years that changed because I suppose with the regulatory framework changing, with the Care Quality Commission and so on, we had to professionalise our systems, and we were the first in the UK to be registered with the Care Quality Commission. And eventually I had to make a decision to leave the NHS and a lot of the locum work I was doing at the time and move totally into the private sector. So I've been doing this now for 25 years, would you believe?
Wow.
So it's a long time, isn't it?
Very long time. But it must be very frustrating being a doctor if you have a patient that has a chronic condition. How do you possibly understand all the symptoms and everything they're going through in 10 minutes?
Well, absolutely. It's interesting. I think that the way we were trained at medical school and the way doctors in general have been trained, up until recently, I think things are beginning to move in different directions now, maybe. But I think we were trained very much to give a label to a disease, and that disease had certain evidence-based treatments with drugs or surgery. But what I found as I've moved through life, in particular as we had illnesses in our own family and also with my son's illness with schizophrenia, I have had a son who's been incredibly poorly. And, I began to seek other routes to understand what I could do, because I felt so frustrated. It was like you were given a prescription and you had, when you became a doctor, and you had to write on it, what the medication was, or refer to a specialist or to surgery. And it seemed like we weren't taught to do anything else. But as I began to, as I moved into the private sector and I had a bit more time, I felt quite guilty that actually, I have people coming to see me who are really poorly, and there must be more than this. And I think at a very young stage, especially when my sister was dying from ovarian cancer, I started to look into alternative routes to heal people and to help, and to really understand, why it was the Chinese chose acupuncture. I mean, they were clever. They had no science in those days, but they had observation, and you had thousands of years of observation and knowledge that, we didn't seem to be taking any notice of. So I trained in acupuncture and I trained in hypnotherapy. And more over the last few years, I've been training in functional or biological systems medicine. So that was the route, really. It was this frustration, that we stopped too soon, and we seemed to diagnose a disease when it got there, but we didn't seem to do anything to help it or help reduce the risk of developing it. And we didn't seem to do enough when we had made that diagnosis. We didn't have enough tools.
Mm-hmm. And of course, it would seem to me that doctors treat the symptoms rather than the cause to find the underlying problem, and then the symptoms go away, that you don't actually need to then treat the symptoms.
I agree. Yes, that's right. I mean, that's really the way we're trained. And I think that was my biggest frustration, and I can understand that, once we've got a serious diagnosis, that sometimes medications can be incredibly helpful in the right place, but they're not necessarily a panacea. Sometimes they are, but, we need to have these other tools and understandings of the body so that we can recognize the causes and the pathway to illness, because if we don't understand that, we can't prevent problems, but B, it's more difficult to turn around some of the symptoms that we are seeing, as you say, at the root cause. I agree with you on that one completely.
Mm-hmm. So how long ago was it when you first heard about LDN?
Interesting, low-dose naltrexone. I mean, I knew about it for many years, actually, with various patients that came to see me when I was working in the NHS who were taking low-dose naltrexone. And at that time, it wasn't on our list of things that we should be doing. And so I probably because I was too busy, seeing so many patients at the NHS, I didn't really look into that further. But I came across it again about 5 or 6 years ago again, when looking at patients who are chronically ill and studying to a much deeper level with functional medicine and biological systems medicine, and trying to understand what was happening with the immune system, because it seemed to me that it became apparent anyway to me that actually many of our symptoms in our bodies, be it headaches or tummy aches or the root of chronic illnesses such as MS, Parkinson's disease, were due to inflammation, and that is so closely tied to the immune system, and therefore there is a disruption in our immune system. And when I think of the immune system these days, I suppose I think of it as, rather than an army who guards us and tries to sort of kill the baddies, I try to think of it as an intelligence service like MI5 that's very complex, actually working out who is for us and who is against us, because actually, under different circumstances, that those situations can coexist, right? Mm-hmm. So I think that in terms of, as I began to understand the immune system and look at, say, for example, for those people who are au fait with the immune system, the Th1 and the Th2 parts of the immune system, and how they become imbalanced for many reasons, and are often associated with underlying conditions depending on how imbalanced they are. It became much easier to understand why a medication such as low-dose naltrexone would work.
Mm-hmm.
And I think, my first foray into that was with people who had autoimmune conditions and whose cellular immunity was not working as well as it might do, and who had probably alongside developed chronic stealth infection, and that actually LDN was a very good tool to be able to correct some of the imbalances that had developed. And as we know, there are many, Linda, many autoimmune conditions, and as we develop these how do you phrase it, sort of imbalances in the immune system or in the intelligence network, that we need more tools to be able to correct those. Remembering also that as we develop problems in the immune system, that really runs alongside some of these chronic stealth infections that then are allowed to develop. So, as I say, what I found with low-dose naltrexone is it's a great adjunct. I mean, sometimes it's very good on its own, but I find that on its own, the body being so complex that no one thing normally is enough to get us better. If I've introduced low-dose naltrexone, it's on the background of someone that understands the importance of the gut and understands the importance of, having a great diet, and a diet that is tailor-made to suit them. We all have different idiosyncrasies with our diet. But really, we've got to be able to work with our lifestyles, our relationships, our exercise patterns, everything really, as well as having these tools that can help to modulate the immune system and give us that extra bit of support at a much deeper level.
Mm-hmm. What have the patient outcomes been? Could you quote us any case studies?
Well, interestingly, I suppose my son was a very good case study in that he had a diagnosis of schizophrenia many years ago. He's 34 now, but he's done incredibly well. I mean, he initially had drug-resistant schizophrenia and eventually was put onto something called clozapine, and he remains on that for various reasons because we're still working with him. And he's now on a combination of clozapine, low-dose naltrexone, and he takes liposomal glutathione. But along the way, we had, remember when the brain is inflamed and when you had neuroinflammation, that our cognitive processes in schizophrenia, and in many conditions, but particularly schizophrenia, completely change, and therefore our perceptions and completely change. And there are times where the brain becomes fragmented. Schizophrenia is a form of dementia, okay? So that we managed to turn that around a lot by diet and by diagnosing underlying stealth infections which were treated. But interestingly, this combination of the medication, which again we're working eventually, hopefully, maybe to reduce that. But at the moment, he's stable on the medication plus. We initially had IV glutathione, and now we're onto the liposomal form, remembering that enters the cells and can pull out metals such as mercury, which we've measured, and we know that that's at the root of his particular problems, part of it. And the LDN, now the LDN, the low-dose naltrexone in him, has been a great success because with schizophrenia, the microglial activation that happens when you've got cytokines, which cytokines are little messengers produced by the immune system, when there's a lot of these around, the immune system of the brain, which is called the microglia, becomes activated. And low-dose naltrexone, we know, calms that down. And it restores the Th1 to Th2 balance. So it means that, the tendency towards infection in autoimmune conditions, and there are many of them, there's obviously the inflammatory bowel diseases, Crohn's disease, we've got rheumatoid arthritis. I mean, there's over 100 different conditions, and many people may not realize that schizophrenia, for example, is an autoimmune condition, but they are all helped when we address this Th1 and the Th2 balance and increase T regulatory cells. So there's a lot happening when we're using this. I've had a great success, Linda, with LDN, and obviously in David, my son, but we use it as part of a multidisciplinary approach because we're looking for particular weaknesses, if you like, or dials that we can turn in our biological systems that the body will be able to shift with. And when we're working on each of those dials simultaneously, at some point there's a shift, and the body is more able to sustain itself in a healthy manner. So and I'd like to see more of this biological systems medicine really taught at university. I believe it's becoming more mainstream. I know Bristol University have a scientific department which teaches the science underlying functional medicine. And I know that actually a doctor colleague of mine, her daughter's training there. So, things are beginning to shift so that we understand, what it is we're trying to do in trying to modulate and change things at root level. Mm-hmm. So I think that's good, don't you? I think that's really good.
Definitely, yes. Now, when a patient comes to see you, and you've got more than 10 minutes, who's obviously got some chronic disease, but they don't know what's wrong with them, how do you go about helping that person when they've walked in and you know nothing about them? How do you set about treating them? What's the roadmap?
That's a good question, Linda. I mean, I have a detailed questionnaire that I really need them to fill out because I like to gain as much information on paper before somebody walks through the door. So it includes a multiple systems questionnaire, for example. Mm-hmm. So I can see quite quickly if somebody's scored like 2 on the multiple systems questionnaire, those 2 symptoms might be incredibly distressing for that person. But as opposed to somebody who's scored 165, you sort of just get this actually. As you get, because I know the questionnaire well, and I know what I'm looking for, and we're asking, quite deep questions sometimes to people to try and to get to think down, the roots of what may be their pathway to illness. And with functional medicine, so we're looking at detailed questionnaires, detailed history, and a roadmap. So you're doing a flow chart often of someone's life just to see where these pivotal points are. And when you do that, it becomes much more obvious at what point and what are the triggers and the mediators and, the pathway to illness, the antecedents, if you like. So, for example, I suppose tick bites and Lyme disease. Acute infections with Borrelia, or even what may turn out to be chronic infection, for example. We refer to Lyme disease as something which is chronic and difficult. In fact, the wording and the nomenclature, the naming of these long-term conditions now are not so much Lyme as something called MSIDS. That's M-SIDS, multiple systemic inflammatory disease and infectious disease syndromes. That's multiple systemic infectious disease syndrome. And these conditions can become chronic. But if you look at this questionnaire and you look at this flow chart as someone comes in, you can see what are the triggers? Is there something recent that suddenly made them present? And pick up where your pivotal points are. And so, for example, in the case of MSIDS or Lyme, if we can pick up that someone lives in a forest or lives in an endemic area, Thetford Forest or the New Forest in the UK, for example, and has had tick bites. Okay, that's not the only thing that's made them ill, but that's a pretty important point that we need to not to miss. And we ask a lot about toxicology. We ask, about exposures, about sensitivities, if people have multiple chemical sensitivities, remembering that at the root of causative medicine, at the root of functional medicine in the end are two things. One, infection, and two, toxic insult or body burden. We want to know what is burdening this person's body that they are suffering with so many symptoms. So you can, as you say, Linda, get, almost list numerous symptoms, too many to list, or you can look at the systems that have been affected that may be producing these symptoms. So that's my map, if you like. Mm-hmm. It's to gain as much information, particularly about everything, but it's particularly at the root cause and particularly infection and body burden. Does that make sense?
Yes. And how long does it take on the first consultation with a patient to go through everything with them?
Well, I would say we normally try to allow an hour because by the time they've come to see me, and people have often seen quite a few different doctors, and so they've got quite a few little tests they bring with them, and they will have completed this questionnaire, which I find enormously helpful because I get a really good feel quite quickly with what is going on because of. Once you've understood and you've worked with systems biology for a long time and studied hard, you can start to see where the pivotal points are, even sometimes before you've tested. So that first hour is critical. I mean, I've seen two new patients today amongst my other patients, but, that took about an hour. And so from that, whilst I'm there, I'll do a flow chart so that I know I can see exactly what's been happening over their lifetime. And I can pull into any tests that may be completely pertinent to just, pinpoint in a little bit more exactly which dials we need to turn to get somebody better. So sometimes we can get a few little tests started on the day, but I don't normally like to do tests the first time I see someone because I like to email everybody with potentially the few tests they may need, and then you can have a little think about them, and then we can have another little chat, often by phone, because people sometimes come from quite a distance, so I don't want to drag them back, so we usually do a little examination at the end of the first hour, and then I'll send them a list of things that I think would be sensible, and then, the sort of a few little thoughts about where I think the roadmap is and why we need these tests, if any. Some people, the test can be quite expensive, unfortunately, so we don't always test. But sometimes it can just target you a bit easier. It's quite in order for patients to go back and get the simple tests from their GP, of course. And we can sometimes, rather than, for example, I do less, just to give you an example, less food sensitivity tests now. I tend to do the elimination diet and take out things that we know can cause problems. And so that it's possible to do things, more pragmatically as well. So, but that's what I did today. So in fact, I've got to go back up in the mountain and do a couple of emails to patients and, think about exactly which tests that we do, and then when we get the results of those, sometimes we can start with low-hanging fruit and then move forward. I'm actually in a situation now where I see a lot of people who have seen different doctors, so usually they've had most of the tests done, by the way, so my job is seeing where the gaps are, Linda, and how else we can support, in ways that haven't been considered at that point.
And of course, a lot of people are still unaware that if they've had tests done by their own GP, that you are allowed to ask for a copy. You can be charged, but everything, you are allowed to have access to everything, and that comes as a shock to people.
Very important. Yeah, it's very important people know that. So I say to them, don't pay for the test that you can have with your GP, and go back and get them. I can write them down what you need, and go and ask for them. And it's difficult because some people don't like to go and ask their GP for tests because they feel that they might get upset or something. So they say, well, if you could, I can write them down for you, and then I can always write to your GPs as well if necessary. I think it's a shame, really, because a lot of doctors, understandably, I would have been in the same position if I'd been in the NHS. You haven't got time and haven't studied it. It takes years of study and understanding. When you look through a lens of root cause medicine, it's really hard, because we're trained in such a different way. But to me, the two can live together well. And the new young doctors that are qualified are clambering out for functional medicine because there's a frustration in the way they're trained. I did some work at the university here recently in Leicester, and we had a few students one by one coming in and sitting with me, and then we had a meeting with them at the end, and I just sat down with them really, and I just told them my son's story, and I said, how much nutrition training have you had? And it was actually 0. And it was a shame. And I feel so sad. And I think to myself, really, when I trained, I didn't know anything about it either, And I think life has changed. It's for the better. I know we say, oh gosh, in the internet and Wi-Fi and EMF, obviously we have to limit our exposure. But I feel like there's a lot that's getting better because people are understanding so much more now. But having said that, I think it must be very frustrating if you're an NHS GP traditionally trained these days, because a lot of the patients that have got anything about them if they've been ill will know more about it than you do as they come through the door, because they've looked at some of the root causes. And I think it must be very frustrating to be a doctor in this day and age with such knowledgeable patients, because for contrary to what a lot of people think, I think Google is amazing for the knowledge it's got on there,
Well, we're nearly at the end of the show, Julia, but just wanted to ask, if the patient goes to their doctor and explains that they've been to see you, would you be happy to work with the GP as well?
Oh, gosh, yes, very much so. I mean, I think a lot of GPs are very, very busy. And, again, some people probably feel a bit upset because they feel a bit threatened, and it's a shame, It's difficult, I think, in some cases. We have quite a few patients who, especially when their children are involved, we have to look after the family and communicate to all agencies, because there's a lot of misunderstanding around children with multiple symptoms, and where a traditional diagnosis cannot be found. Sometimes there's a lot of pressure put on the families that maybe they're making them up or making the child ill or whatever. So, I do a lot of work with working and explaining carefully what we're doing, and actually that there is some problem going on here, and here are the test results. And so we do that, and sometimes it can be very difficult, because people do feel a bit threatened, especially when they don't understand something. And obviously we're working with situations and with thought processes that are out with the NICE guidelines. And so having said that, B12 injections and how we use B12 is something that's actually within the NICE guidelines, and sometimes you end up, just explaining, well, actually you can give this because this person has no neurological condition, and that's what it says in the NICE guidelines. So sometimes you have got that backing, but I think the answer is yes. We will work with the NHS and with doctors, and we should be working as a team, and we should be trying to separate things out. But sometimes in reality we have to, but that's the decision of the patient. When it comes to a child, there's no choice, because there are times, particularly where because of children in need or child safeguarding, we are compelled to communicate, and we have to communicate. So am I making that?
Yes, I understand.
Yeah, basically the answer is yes, and sometimes there's a choice in it, and sometimes there isn't.
Okay. Now, if people want to come and see you, do you have a waiting list?
Not at the moment. No, we don't. We have, and also, I think at the moment, I don't work all day, every day seeing patients, because I try to keep a balance. But we have other doctors here who I work with, and we have a lovely health coach, and a nutrition coach, and a nutritionist. So who come and work with us as well. So that's the way we do it. So sometimes if I don't need to do everything, then I can ask someone else to help with certain things. And I find that you can sort of work out what you might need to do in life, and then you need that little bit of extra sort of access from a motivational perspective for how you actually make that change, because sometimes that isn't so easy, so it's not just me, and then we've got other people that we know that can help as well.
Wonderful. So could you give us your website address, please, Julia?
Yes, it's privategp.com, and you're obviously very welcome to have a look. That's sort of, we rebranded this year. Before we were very much more like a traditional practice, but I think my daughter said to me, "Mum, you need to make your website who you are," and so she helped me to do that. And it was difficult at the time. I remember my father was very poorly, and we lost him in the end. But I found it, somehow we managed to do it despite everything, and we did it. We launched it in May this year, and I hope you like it. So any feedback would be gratefully received.
Oh, all I can say is thank you very much for sharing your experience with us today. It's been really interesting.
A pleasure. Thank you very much, Linda.
This show is sponsored by Dixon's Chemist, who are the experts in LDN and associated treatments in the UK. Dixon's Chemist are the most cost-effective for LDN in all forms within the UK and Europe, maintaining safety standards far in excess of what is required. Why would you choose to get your LDN from anywhere else? Call 0141 404 6545 today to speak to their LDN experts. New for 2020, our LDN radio shows will be available on Spotify and iTunes. They will also be transcribed and added to our website, ldnresearchtrust.org. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.